All right. Well, thank you very much for allowing me to present to this group here. And I know some of you experience or are in the area of gastroparesis. And so, what G-PACT asked me to do is to talk about my research in small intestinal bacterial overgrowth and to try to put gastroparesis in that context. And for those of you who don't know what bacterial overgrowth is, you will by the end of this, and I hope I can explain it as clearly as possible. This is my lab. I'm just showing you this because our lab focuses on it's called the MAST program at Cedars-Sinai Medical Center in Los Angeles, and we focus on the effect of motility on gut microbes and the effect of microbes on gut motility as well. And where we've discovered some very important things, we think, and including rifaximin was our discovery for the treatment of irritable bowel syndrome. So you may be familiar with that drug. So we've done a lot over the years, and we continue to try to push the envelope of trying to find causes of conditions. One of the philosophies I have in the clinic here in the motility clinic at Cedars, and that our entire group of about 6 physicians is that we like to treat the cause of the disease, not just treat the symptoms to the best of our ability. We want to identify those causes. And so, um, in that context, we think bacteria and gut microbes play a role in some of the causative agents in human disease. I'll try to put that again in context of gastroparesis. One last slide before I get started. One of our claim to fames at Cedars in the MASS program is a study called the Reimagine study. So if you don't know anything about the gut microbiome, there have been about 140,000 publications where the word microbiome is in the abstract. And in those 140,000 publications since around 2005, when the first human microbiome project was published in Nature, almost nothing. Uh, um, Let me say it a bit differently. We don't have any real smoking guns from colon, from stool. And so our focus was, well, maybe the focus shouldn't be on stool because that's your waste basket. Maybe the focus should be on the small intestine, which is 15 feet long, right near the stomach. That's where the stomach delivers food. That's where the pancreas delivers its enzymes. That's where the liver is controlled. That's where all the hormones are produced, that the gut hormones that control the stomach, that control the physiology of your body, GLP-1, etc., all these different hormones. And so maybe the small intestinal microbiome is important. So we have the largest collection of small intestinal aspirates taken during endoscopy in a human research project, and we're looking at various diseases using a variety of very technical tools, including shotgun sequencing. We published the first shotgun sequencing of the human microbiome of the small intestine ever. And we're trying to characterize illnesses based on the small intestinal microbiome. And we have found 5 smoking guns in the last decade. And so though you're going to hear a lot about those different bacteria that we've identified as potential causes of diseases, including more on IBS, polycystic ovary syndrome. We've identified a bacteria that produces testosterone in the small bowel and could be causing PCOS. Reflux disease is the next one. We have a bug that we think could be contributing in part to reflux disease. And then, of course, gastroparesis. We'll talk a little bit about that, but I hope to give you some very useful information nonetheless. But my focus of talk today is on what we call microbial overgrowth syndromes. If you're in medicine, you might know this. Even those outside of medicine understand that H. pylori is a cause of ulcers in the stomach. Barry Marshall won the Nobel Prize for that finding. And what we know about H. pylori is that probably 60% of people over the age of 60 have H. pylori in their stomach. It's very common, but it doesn't cause ulcers until it grows too much, causes too much inflammation, and then the ulcer forms. So maybe H. pylori is normal, but when it overgrows, that's when you get an ulcer. I don't know how much you know about C. diff colitis, but probably most of you have heard this term. It's a very devastating colitis that occurs after you take an antibiotic because you were exposed to C. diff and you have it colonized in your colon. Well, 45% of children under the age of 1 have C. diff colonizing their colon, and that's perfectly okay, but it isn't the fact that you have it, it's the fact that it overgrows, and so it's really an overgrowth phenomenon. C. diff is fine until it overgrows or takes over, and then you get C. diff colitis. Yeast is another thing. You have yeast in our stool, we have yeast in our on our body, but we don't get thrush in our mouth until we take an antibiotic or we have immunosuppression from chemotherapy. Then all of a sudden the Candida overgrows and you get candidal esophagitis or thrush in the mouth or yeast in the pelvis, and pelvic organs. But what I'm going to focus on are E. coli, Klebsiella, Methanobrevibacter smithii, and hydrogen sulfide producers as important to gastrointestinal function. And when they overgrow, they change gastrointestinal function. And so my focus is on this umbrella term, small intestinal bacterial overgrowth. And uh, as I try to explain the causes of SIBO, I want you to understand that anything that slows the intestinal tract can cause SIBO. So SIBO, or the buildup of bacteria in the small intestine, is the result of things not flowing well. So SIBO is never there. It's always there because of some problem that happened. So scleroderma, for example, will slow your gut down. Diabetic neuropathy, which also causes gastroparesis, slows the small intestine down and you get a buildup of bacteria. So it's like you've got a slow drain in your sink and the sink is dirty all the time because the water doesn't drain well. That's basically what small intestinal bacterial overgrowth is and how it relates to problems with motility. And gastroparesis, for its part, is a manifestation of slow motility, can also be from the same causes. Diabetes causes gastroparesis, scleroderma causes gastroparesis. Um, Anything that's obstructing the bowel can cause gastroparesis because the bowel cannot move and the stomach cannot empty. So there are myths about SIBO, which I'm not going to get too deep into, but the old school SIBO was caused by surgery that we did as physicians back in the 1960s when we didn't have Nexium for acid. We cut the stomach out to get rid of that ulcer that's bleeding over and over and over again, or perforated ulcers. We would have to do surgery on them because we didn't know how to make them go away. And so that resulted in all sorts of altered anatomy that led to bacterial overgrowth. But what we're talking about, and when we talk about overgrowth today, we're really talking about the overgrowth that occurs in a natural bowel for unnatural problems that occur, like diabetes and other things. So generally, gastroparesis is broken down into diabetes and idiopathic. But that's a little bit too simplistic because there are many things that can cause the stomach to delay, including bowel obstructions and other things which I've already mentioned. And so it's important in gastroparesis to fully work up a patient in order to understand why the stomach is not emptying and to make sure you understand that and that it's because there's a difference between treating gastroparesis because you have an obstruction in your bowel versus the stomach muscles and nerves just don't work, and how you manage that is going to be very, very different. But gastroparesis is a little bit tricky in making the diagnosis accurately. I would say at our center, to be frank, many times we actually remove the diagnosis because it was incorrect. So if you do a stomach emptying test and it's abnormal, the only thing the abnormal stomach emptying test tells you is your stomach emptying today at 8 a.m. is slow. It doesn't mean you have gastroparesis. It just means today at 8 a.m your stomach is slow. And so you have to be careful with the diagnosis of gastroparesis that you don't use the gastric emptying test in an overreaching way. So it has to be in the context of the clinical symptoms and other pathophysiology or other reasons for why the stomach is behaving in this way in order to make the diagnosis more firmly. Most of my research is on irritable bowel syndrome, so I will spend a little bit of time on that. But what I want to say is that going back to gastroparesis is associated with SIBO, as you'll see, because the nerves, if you have true gastroparesis, where the nerves and the muscles of the stomach are not functioning well and food is building up in the stomach, there is no line here that says, hey, neuropathy, stop here at the pylorus. Inevitably, anybody with gastroparesis, their small bowel is also affected. Inevitably, anybody with a small bowel neuropathy, their stomach is also affected. So there is no dividing line that says gastroparesis only, not small bowel, or a small bowel only and not stomach, because they're in continuity. So any neuropathy that affects the stomach affects the small bowel and vice versa. That's basically what I'm trying to say. So you would expect, therefore, that since diabetes causes neuropathy of the stomach and the small bowel and SIBO, that SIBO is very common in gastroparesis. The symptoms of SIBO, before I jump into sort of IBS, are it depends on the gas, it depends on the type of microbes that develop. But typically, bloating after eating is the big one. And that's the one that really is the most uncomfortable because it can cause pain and discomfort. It could also put more pressure on the stomach of gastroparetic patients, making them want to vomit more. And so this bloating and distension is really a problem. If you have isolated stomach not emptying, there's not much bloating. So if you're having bloating and you have gastroparesis, because think of it this way, the stomach is about this big, the small bowel is this big. If this big thing bloats, it really puts pressure. If this thing grows a little bit, it's not as much physical volume in the gut to make you feel that the abdomen is actually extending. So the small bowel has to be involved in that case, and overgrowth is likely. But again, all I've tried to tell you during this presentation so far is that our philosophy is root cause, root cause, root cause. I do not like the 30 years of my career where I'm being told to take a laxative for constipation or a antidiarrheal for diarrhea for IBS. I think that is not the way we should approach IBS. I think we need to figure out the causes of IBS, the subcategories within IBS, and treat those as root cause, or we'll never find out what's going on with IBS. And so to that extent, I'm going to show you some data which are a contribution to trying to figure out root cause. But it has a very important overlap with gastroparesis, because in the idiopathic form of gastroparesis, one of the notions is that gastroparesis is a post-infectious condition, a post-viral, or maybe even post-food poisoning. So I'm going to show you some of the data on irritable bowel syndrome where there's nerve damage and damage to the cells, the interstitial cells of Cajal, for which there's a fair bit of data that these ICCs, or these nerve cells of the stomach, are also damaged, causing gastroparesis. And we now know that about 60% of IBS is SIBO, but the root is food poisoning or infection. So I'm going to focus on IBS over the next few slides and then carry it back to gastroparesis just to try to help you here, but to help you understand that there may be overlaps. The challenge with gastroparesis is let me put it this way. Inflammatory bowel disease research, there's this much money to do research in inflammatory bowel disease from the NIH. There's this much money for IBS, even though IBS is 20 to 100 times more common. Now, gastroparesis is less common than IBS, but there's this much research for gastroparesis. So the funding for motility disorders, IBS and gastroparesis combined, is trivial compared to IBD. And I'm not saying IBD is not an important disease, but it's disproportionately favoring IBD, which means we don't get to do all the good stuff. We don't get the resources to do the good stuff and the right stuff we need to do for these conditions. We're doing our best. A lot is coming along in IBS, but a lot of what we're learning in IBS could easily then translate into some good research for gastroparesis over the coming years. But here it is, food poisoning. This is a breakdown of all the studies that looked at food poisoning and the development of IBS from 2024. If you go to a wedding and that buffet is contaminated and 100 people at the wedding get sick from food poisoning, 14 out of 100 people who got sick from food poisoning will now have IBS, maybe for the rest of their life. So that's how common it is. 1 in 7 people would get food poisoning. If that food poisoning is Campylobacter, look at the far right, it's 1 in 5. So 20% of people who went to the wedding, if that buffet had Campylobacter, would now have irritable bowel syndrome. And the way this works is interesting. But before I get to that, one of the traditional things in medicine, which is very frustrating, is that when physicians don't understand a condition, they think it's due to stress. For decades, IBS was attributed as it's due to stress, anxiety, depression, previous trauma, life trauma. And this study from troops deployed to Iraq and Afghanistan in the 2000s, these young people went to Iraq and Afghanistan. They didn't have IBS. Many of them sure came back with irritable bowel syndrome, and they looked back at their deployment experiences, and the people experienced all sorts of things, traumatic things we would never experience here in the United States. Firing your weapon, killing people, seeing people killed, losing a limb. These sorts of traumatic injuries or traumatic experiences had nothing to do with the development of IBS. The only thing that was linked to development of IBS was, did you get food poisoning when you were in Iraq or Afghanistan? So the point I'm trying to make here is that food poisoning is doing something to patients, and it's not stress and anxiety and all the stuff we've been saying for decades. But this food poisoning toxin, the cytolethal distended toxin, it's the only toxin that's shared by all 4 bugs that cause IBS. And this toxin is really special because it makes you form antibodies to yourself. So you form an antibody to the toxin when you get the food poisoning from Campylobacter, for example, and it forms it to this protein, human vinculin, which is an extremely important protein that helps the wires of the nerves of the gut, the interstitial cells of Cajal that are so important in gastroparesis and gut function for cleaning, to connect. And so if you don't have human vinculin or if you have these antibodies, this protein is diminished. As a result, the nerves are less populated, so there's less ICC cells, and there's more neuropathy of the gut. And we believe that this neuropathy caused by these antibodies, caused by food poisoning, could be what causes SIBO and IBS. And I'll show you data on that. But we now use these antibodies. They're available commercially, and they can tell you you have IBS and you do not have Crohn's disease, or you have IBS over Crohn's disease. So to the extent what these antibodies do is they say to a patient, it's not in your head, you have a disease. This is the marker that tells you food poisoning caused your IBS, full stop. So it's very important that a biomarker is developed so that you know that this is what's causing your illness. And it gives you a post-test probability of over 80%. 80% is the cutoff for medical certainty. And, if both markers are positive, it's 98%. Now we're going to move into sort of the microbiology of this. We can now give this toxin to rats in their back like a vaccine, and they get IBS. So these are rats, they got the toxin, anti-CDTV, they develop the antibodies, and they get diarrhea. And the diarrhea is proportional to the antibodies. But then the rats get overgrowth of bacteria of the gut because of these antibodies. And they get one of 2 types of overgrowth: E. coli overgrowth, which is hydrogen producing bacteria, or desulfovibrio overgrowth, which is hydrogen sulfide producing bacteria. Now, this is really important because now there's a 3-gas breath test that measures hydrogen, methane, and hydrogen sulfide. And they all could have an important role in gastroparesis. Certainly they do in IBS. But here's where it gets exciting, is that this anti-vinculin antibody, which damages the cells of the wall of the intestine, which are important for neuropathy of the small bowel, and are known to be important for gastroparesis. If these antibodies are present and we can force them down, the IBS disappears. So IVIG, plasmapheresis, if we can get these antibodies to normal, 75% of those people had normalization of their symptoms. In the patients we did plasmapheresis on, you can imagine plasmapheresis is like dialysis for antibodies. So it's a big deal to do this in humans with IBS. They have to be really sick. But when we did this, the IBS symptoms disappeared. So we think we might be able to cure IBS who have these antibodies if we can get rid of this antibody with a drug rather than with these aggressive forms of therapy that we're talking about on this slide. So, important questions from gastroparesis that have not yet been answered. Could these autoantibodies like antivinculin be important to gastroparesis? Well, J-PACT in Arizona has shown that antivinculin antibodies are important in gastroparesis, but it needs to be explored further. And are associated with reduced ICCs in gastroparesis. So, really important context, need more work, resources to focus in this area. So the way we diagnose small intestinal bacterial overgrowth in humans is a breath test. So the way the breath test is done is you get your breath sample. So you get a baseline first thing in the morning after fasting. Then you ingest a sugar. Usually we do lactulose, and I'll tell you why later. Lactulose, though, is a non-absorbed sugar, so it gets through the whole small intestine, and when the bacteria see it, they ferment it, and they produce gases that humans don't produce. The three gases that they produce, we don't produce, are hydrogen, methane, and we don't produce a lot of hydrogen sulfide. They do. So, but this is the hydrogen only aspect of the breath test, and IBS patients are head and shoulders above healthy controls. So if you're IBS, you're more likely to be positive on the breath test, which indicates that you have small intestinal bacterial overgrowth. Now, there are a few studies in gastroparesis on this. This is a meta-analysis from 2023 by BS. 40% of patients with gastroparesis have SIBO, but this is complicated. So this is using breath test. The reason it's complicated is when you do a breath test, when you drink the sugar, if your stomach doesn't empty the sugar, the breath hydrogen won't go up. So if we're seeing 40% positive with gastroparesis using breath tests, it's likely much higher than that because in some of those patients, the sugar just never gets out of the stomach. So it's a little bit more challenging with gastroparesis to diagnose SIBO, but we know it's there, especially if patients have that bloating and distension we talked about at the beginning. Now, I've mentioned the SIBO testing is a little complicated in gastroparesis because the lactulose is a hard time getting out of the stomach, just as everything else has a hard time getting out of the stomach. GLP-1 drugs, this is important because it sort of puts this notion into context. Same issue that slows stomach emptying down. And we can't even do breath tests on GLP-1 patients because lactulose never gets out of the stomach. And that's basically the same point I'm trying to make with gastroparesis. Treatment of gastroparesis SIBO is a little bit difficult, although we'll get into some treatment techniques here shortly. But treatment's difficult because the medications don't get out of the stomach. And even if you wanted to go in and get a culture of the small bowel juice to see if you have overgrowth, there's so much debris in food that it makes the accuracy of culture difficult also. But what we know from studies that have been done on breath testing, this literally came out just a few months ago, is that there are people who are high hydrogen on breath test and people who are normal hydrogen on breath test, and there's not a lot in between. But the people who are high hydrogen on breath test, they will respond to antibiotics. So a breath test is important to stratify who's going to respond. I mentioned that um, we were the first to do what's called shotgun sequencing of the human small intestinal microbiome in the world, and we did this in SIBO. Now, one of the things about small intestinal bacterial overgrowth that's very, again, old school thinking is that SIBO is colon bacteria moving up into the small intestine. That's not SIBO. We now know that's not SIBO. SIBO is the gut is now slow. And the bugs that are just at low numbers in the small bowel normally are aggressive and take over, and they're the Ferraris of fermentation. And what we found was that SIBO was really two organisms. This isn't stool. Stool has thousands of organisms. This is E. coli and Klebsiella pneumoniae. So if you took a sample from a patient with SIBO, you took a bit of juice from their small intestine, and 46% of every single bacteria in your small intestine is two species, Klebsiella pneumoniae and E. coli. That was even shocking to us. So Kleb and E. coli are the SIBO Ferraris. And when I say they're Ferraris, I mean they're Ferraris. When you have SIBO, when we looked at the machinery to produce gas from glucose in a SIBO patient versus a non-SIBO patient, the SIBO patient produces gas 63 times faster than a normal person. So they're able to degrade glucose and produce gases. So when a patient says they eat and they feel bloated 10 minutes later, you better believe it, because when they have SIBO, this is the dramatic bloating effect of having these Ferraris there. Um, the world is all into SIBO now. SIBO was controversial 20 years ago in the context of IBS, but now there's consensus statements from all over the world. Most recently, which I haven't added, is Argentina did their consensus. So we're we're almost all on the same page about SIBO in the world. But SIBO became complicated recently, but it became clearer recently. So there were always three gases that are produced by bacteria of the gut. Hydrogen sulfide was just difficult to measure because hydrogen sulfide is very reactive. So, anyways, hydrogen is produced by bacteria, methane is produced by bacteria, and hydrogen sulfide. And when hydrogen sulfide is present, it's really associated with bad diarrhea symptoms. Methane causes constipation and slowing of transit. And this also becomes very important potentially in gastroparesis, which I'll talk about. So now we have three types of overgrowth because of this new three-gas breath test. You have the conventional small intestinal bacterial overgrowth, which is hydrogen, the intestinal methanogen overgrowth, which is methane, and the intestinal sulfide overproduction, which is hydrogen sulfide. So this new three-gas breath test, which is available, can now measure all these three gases stably. It gets sent to a CLIA-certified lab, so it's done at home, and it's validated for IBS and is the most validated breath test in history. But again, focusing on IBS because that's where most of this work is, when you're constipated, you have methane. When you're diarrhea, you have no methane, which is the blue line here, no methane. So methane is associated with constipation IBS. IBS-D is not associated with methane. IBS-D is associated with hydrogen being elevated, which is the blue line here, and hydrogen sulfide being elevated, which is the blue line here. But all of this work has now come to the point where we know the three gas types and we know the bacteria and the bugs that are producing these gases. In this case, for methane in this study, we now know it's not a bacteria, it's an archaeal organism called Methanobrevibacter smithii. The higher the breath methane, the higher this bug is in the gut of the human. And you can see the correlations and the p-values here. So we know the bug that's producing methane. Can we develop drugs to treat that bug, get rid of it, or get rid of the methane, and have better drugs in the future to stop the slowing of the gut that this methane does? We now know if we measure the breath of a human for methane and they go and grab the juice from the small intestine, the methane correlates with the bugs in the juice of the small intestine as well. And again, the most common character is this Methanobrevibacter smithii. But this is probably the most important slide because it could have reference or pertinence to gastroparesis. Methane gas. It is not the methane organism. It is the methane gas that this bug produces that slows the entire gastrointestinal tract. So the higher the methane, the slower your gut is. So If you have gastroparesis and methane, your gastroparesis is going to be worse. If you have very high methane, your stomach is going to be slower. So knowing if you have methane or not and treating the methane can make the gut function more normally. And let me just help you understand how methane works. Anytime we put methane into the small intestine of an animal in this animal study, the animal's transit time slowed by 59%. So you're basically cutting the time, doubling the time it takes to move material through the gut. But this is a guinea pig ileum in an organ bath, and you can make peristalsis very beautifully with oxygen in the bath. But when methane and oxygen are in the bath, the gut is spasming and not allowing movement. So the way methane works is it doesn't paralyze your gut. It makes your gut hold everything in place with contractions. So it's a different kind of slowing than sort of a paralysis kind of slowing. And so now there's studies here looking at methane is associated with constipation, looking at all the studies that have been published, and associated with less diarrhea. But this is a really important study. So this is using a wireless capsule to measure transit from a group from Stanford. If you have methane, your whole gut transit is slower. And so we know methane is associated with slowing of the gut. So how much work is there on methane and gastroparesis? Well, very little, ironically. And so more work needs to be done here because methane slows the gut down. So, and that includes the whole gut. So it's important to understand whether in a particular given person, could they have methane? And if they have methane, could getting rid of it improve their gastroparesis even by a small percentage, enough to make them feel more comfortable? But certainly methane causes more bloating, so it can be important to improve symptoms regardless. So if you have gastroparesis and constipation, methane might be important to you. Now, hydrogen sulfide is the third gas that's been added to the breath test, and it is associated with a whole group of organisms that produce hydrogen sulfide. Um, but if you're going to do a breath test and you're going to do it from home, you should use lactulose. Glucose misses people who could benefit from the breath test results because glucose gets absorbed so quickly by you. And if you have gastroparesis, it's going to be absorbed in the stomach because you can put glucose under your tongue. It gets absorbed. It just gets absorbed everywhere so quickly. So you need to use lactulose because it's not absorbed at all. And even in gastroparesis will get out of the stomach eventually and allow you to do the test. So do not do glucose. And hydrogen sulfide is associated with diarrhea. So the more severe your diarrhea, the higher your hydrogen sulfide and vice versa. But we now think hydrogen sulfide is the most important of the three gases in terms of severity of GI symptoms, because anytime hydrogen sulfide is present, the overall symptoms are worse. So hydrogen sulfide is very toxic, as you probably know. Hydrogen sulfide is a toxic gas in general, and it is very toxic to human cells. So we've got now these three buckets. We've got the regular SIBO in the middle, which we now know the culprits are E. coli and Klebsiella. We got methane on the right, which is the intestinal methanogen overgrowth, and that slows your gut down. And then the new hydrogen sulfide in on the far left, causing more severe diarrhea. So how do we treat overgrowth? Well, you know, most of you might know rifaximin was FDA approved for the treatment of for the treatment of irritable bowel syndrome with diarrhea in 2015, based on, in part, these two big randomized control trials. So rifaximin works very well for IBS, and it was the first drug that you treat for 2 weeks, and IBS stayed better because you're treating a potential mechanism, and the FDA recognized that it's affecting the microbiome in some way positive, although now we know it's probably SIBO because of this study. In 2019, 4 years after the FDA approval, we looked at the breath tests in the controlled trials, and we found that if you just closed your eyes and gave rifaximin to IBSD, 44% of people would get better. If the breath test was negative, though, less people got better. because breath tests predicted who were going to respond, because 56%, much higher percentage of people got better if they had a positive breath test before they started rifaximin. And if rifaximin worked and made their breath test negative, 76% of people responded. Now there are meta-analyses on trials for rifaximin for SIBO, and rifaximin is very effective for SIBO. In IBS itself, if you do a breath test, you're more likely to respond to antibiotics. I want to talk to you a little bit about the safety of rifaximin in contrast to tricyclics. There were some tricyclic trials in gastroparesis which failed. I'm not surprised because tricyclics slow the gut down, but tricyclics have a lot of potential harm, or patients don't tolerate tricyclics well. As you can see, 2.3 people respond to for every 2.3 people who respond to tricyclics, one person has to stop the drug because they're not feeling good with the drug, side effects, in other words. Rifaximin, 846 people would get better from rifaximin before one person would stop the drug. In a recent repeat of this trial, now that we have more drugs and more studies, rifaximin is infinite, and that number is infinite because in the placebo group, more people stopped the drug than in the rifaximin group. And so rifaximin is more safe than the placebo, you could say, but tricyclics remain in and around 18 to 24 patients for number needed to harm. Now, if you have methane, you can't use rifaximin alone. You have to add neomycin. And this was based on some data in the laboratory that we got. And then we translated that into this double-blind randomized placebo-controlled trial. And you can see that, the constipation score was reduced most in the rifaximin and neomycin group. For hydrogen sulfide, bismuth works well, Pepto-Bismol, and so we use that in combination with rifaximin in my office, although we're waiting for some important randomized controlled trial data. This is an interesting study on using elemental diet. This can be very helpful in patients with gastroparesis, potentially, but it hasn't been studied yet in that way. But the way an elemental diet gets rid of overgrowth is all the food's already broken down for you. You don't have to do anything. It just gets absorbed. It's the amino acids, not the proteins. That's what's in here. It's the fatty acids, not the complex lipids. It's the simple sugars, not the long chains of carbohydrates that you would get in a typical meal. And so they get absorbed so quickly, and you can see that they starve the overgrowth out, because this is what methane looks like before elemental, and this is after. It's perfectly normal. This is the breath test of hydrogen before elemental, and then after. It's below 20, so it's normal. So, and the symptoms improve. An elemental diet can really relieve bloating because there's it doesn't encounter the bacteria, and therefore there's less gas to be produced because there's less fermentation. Now, prokinetics are really important in the treatment of SIBO. We saw this in 2009, and now we use the newer agents like motility, otherwise known as prucalopride. Prucalopride is used quite a bit in gastroparesis, and I use it in gastroparesis in my practice as well to help the stomach hopefully empty better, help move the small bowel, and it can also make the cleaning waves of the gut go to prevent overgrowth. So once you've treated overgrowth, if you did nothing, it could relapse as early as 60 days. If you use erythromycin as a prokinetic, that jumps to about 140 days. But if you use the serotonin agonist, which motegrity is, you get almost 250 days of remission without needing another antibiotic treatment, without needing rifaximin again. So the way I handle these patients in my clinic and those who are relapsing is I give them the treatment for the overgrowth, and then they get a prokinetic to keep it away so that we don't have to keep giving rifaximin over and over again. And then finally, I want to show you some optimistic things that are coming in the future. Now that all this beautiful data is here, and this is the importance of physiology research, trying to understand the root cause of conditions. We now have a drug in our lab that can go into the enzyme in the bug that produces methane and stop the methane production. And by doing that, the rats have less constipation and less methane in their stool. And so we're in the midst of preparing the FDA for a clinical trial, hopefully next year, the first human trial of an anti-methane drug for methane. If you stop the methane, You stop the slow transit. If you stop the slow transit, you're going to have relief of symptoms. How that pertains to gastroparesis really needs to be explored, and I think there's a future there as well. On the SIBO part, in patients with gastroparesis or IBS, we now know the cast of characters for SIBO, and the hydrogen sulfide producers are here as well. And these guys have flagella, and they live in the mucus half-time and half-time in the above the mucus layer. Rifaximin can only get the bugs above the mucus layer. It can't get into the mucus because rifaximin doesn't dissolve in water. So we came up with the idea of combining rifaximin with N-acetylcysteine, which is a mucolytic. And by doing this, we can make IBS patients from this with just rifaximin alone to this with rifaximin and NAC. And we're in the middle of a very large scale, 3-center randomized control phase 2B FDA trial using rifaximin and NAC as the next generation of rifaximin to get people much better than rifaximin alone, we hope. That's the hope. So in conclusion, gastroparesis is associated with SIBO, but the research in this area is still nascent. Need to do more work here. Like IBS, gastroparesis is a post-infectious event, and there are antibodies that occur after an infection that can affect the interstitial cells of Cajal of the small bowel, and some limited data on gastroparesis. Without doubt, gastroparesis is associated with overgrowth, and breath testing can become important, but you have to understand the nuances of breath testing in a patient with gastroparesis. The new gas types and understanding the gas types is going to be very important because methane slows intestinal transit. And so getting rid of methane could be important in helping patients with gastroparesis and constipation possibly as well. And you should think about prokinetics after antibiotics to help these patients optimize their management. So thank you so much. I've tried to provide about 15 minutes for questions if anybody has any.
Thank you for that. I just wanna say from my perspective, I learned a lot, so thank you. Um, I see, we do have a couple questions in the chat, but I see that Alex raised her hand. Alex, do you wanna unmute and ask your question?
My second question is that I've been doing immunoglobulin. I do subcutaneous immunoglobulin, and I've had slow transit constipation my entire life, 30 plus day transit time. I've had it tested multiple times. Supposed to have my colon out, all that, but it switched suddenly overnight to severe diarrhea that has not let up, like 20, 30 times a day. Nobody can figure it out, but IVIG stopped it almost immediately, like within the first week of my loading dose. So I'm curious, you were talking about, and I see you talk about it in other lectures, that IG could be fixing people's SIBO. Do you
Yeah.
feel that if I'm already on it for other reasons, is that an optimal treatment, or is it still worth treating in other ways? Like because it sounds like what you're saying is with the slow digestion that we have, we're still going to keep needing to treat over and over, right? And we
Yeah.
can't,
I mean,
yeah.
yeah. So your case is quite complicated, but super, super up our alley. This is the kind of stuff we see here all the time. If we dissect things further, I bet you we could be able to help you in other ways. But I think to to give you a clear answer, what I can tell you is IVIG has helped a lot of patients in our practice who have these auto antibodies. You probably never got those antibodies measured at Kaiser, would be what I imagine. So you don't even know. So I think, getting sort of all this stuff, all these tests done so that you understand more clearly what's going on would be very helpful.
Yeah. Okay. I'll make an appointment. Thank you.
Yeah, no problem.
I've got one from the chat. Eva, I see your hand up. I'll get to you in just 1 second. It says it's a long one, so I will summarize it. Female with idiopathic gastroparesis for 15 years. Experienced a setback and diagnosed with IMO the last 5 years. Been on low FODMAP gastroparesis diet for those 5 years. Done herbal treatments, and I'm on the third with ppm levels dropping each time so far on domperidone 10 milligrams twice a day. focus is that iron came back anemic. Do most SIBO, IMO people go low iron, and does that slow motility even more? And do the iron supplements feed into the SIBO, IMO, or cause worse biofilm?
Uh, so a lot to unpack here. I can't give you medical advice because I don't know everything about you, but what I can tell you is that in our practice, patients on these very restrictive diets often can get iron deficiency due to the diet, not necessarily due to the GI illness. Iron supplementation can make constipation worse, especially if it's by mouth, less so by iron infusions. So we sometimes switch people from oral to iron infusions to mitigate the effect. The other thing is if you have SIBO or EMO, so if you have if you have EMO and gastroparesis and some of the other symptoms that you have, in my practice, we would be very much gravitating towards an elemental diet approach to this to try and get the EMO back to normal and then use a prokinetic like motegrity to keep things going. We don't use domperidone that often. I know domperidone is very good for some gastroparetic patients if nothing else works, but happy to use it. But motegrity, we feel in the right hands can be even better than domperidone. So there's a few things that can be handled here that I think would be very helpful.
Um, okay. Eva, do you want to unmute and ask your question?
Yes, thank you, Samantha.
Mhm.
Um, so my question is about breath tests because I have severe gastroparesis, have a GJ tube. I'm not currently able to feed, but when I take prokinetics like Motegrity, I my small intestine produces a lot of gases and is uncomfortable. So this weekend, we tried to get around this with a breath test by I took one breath test orally and then I took with lactulose. Then I took another breath test where I put the lactulose through my J tube.
Different
But we
days,
were
right?
just kind of, guessing. So do you think that is likely to produce a better picture of what is going on in my gut?
You saying taking lactose by mouth or by tube, which one will show a better picture? Is that what you're asking?
No, I actually did both. So what my GI decided to do was because we don't think I've gotten an accurate SIBO test ever
Yeah,
because liquids have a really hard time leaving my stomach. I
yeah,
actually do have some motility in my stomach. It's the upper part is paralyzed, but the
yeah.
lower part has motility. But my everything stops at my small intestine.
Got it.
Um, and so we were trying to get a picture sort of beyond my duodenum. And that was why we also did a breath test, having put the lactulose through my J tube. My question is, and like I said, that was just a best guess on our part to try to measure what's going on because we
Yeah.
know that things aren't going through. So my question is, I guess, do you think I'm likely to get a better picture of my small intestine having put the lactulose in my J tube? And then once I have done that, like as you're talking about the motegrity, um, since this is likely to be coming the dysmotility in my small intestine seems to be worse than that in my stomach. It sounds like what you're talking about is I'm likely more to be seeing uh I just blanked on the gas. Um
Methane?
Methane. Yes, I'm more likely to see methane. And so you're suggesting, and I'm not asking for a medical opinion, but just based on
Yeah.
the data you saw, that is likely to be more effective with rifaximin and motegrity.
So if you have methane, the treatment that's recommended is rifaximin plus neomycin because that will get the methane down. But
Okay.
I'd have to see the breath tests because if you did a breath test by mouth, I could tell if it was a gastroparesis breath test because of the way the profile looks. So I could tell whether it was good enough and you don't need to do it by tube. But if you've done both, then that's even better because then you can really see things. And the gases will tell what can be done. But in terms of motegrity, just and this is something even the gastroenterologists don't get, and I don't know why. But even some of the motility doctors don't talk like this, and I'm not sure why they don't understand this. But if you take a prokinetic like motegrity and you take it in the daytime, you are going to make the meal-related motility more. If you take the motegrity at bedtime, you are going to only make more cleaning waves of the gut, which keeps the bowel clean. So if you give motegrity at night, you're not going to get the bloating. You're going to have less bloating because you're cleaning the small bowel through the night with the motegrity. If you're going to take the motegrity during the day and you're forcing all the tube feed further down, you're going to have more bloating, gas, and distension. And I wouldn't give motegrity in patients who are getting fed through a GJ because they're going to get more bloating because you're going to shove all that food down into the colon and it won't even be, have less time to be absorbed as well. So it could be why in some patients motegrity with tube feeding during the day is a bad idea because you're just going to get more bloated. So anyways, I think that's may explain part of what you were saying.
Thank you.
Victoria, I'll get to you in just one second. I want to grab a question from the chat asking, what do you think of Cipro to treat SIBO?
So back before we had rifaximin, we were using neomycin, doxycycline, augmentin, Cipro, Flagyl. We were using even tetracyclines sometimes because we were fishing for the antibiotic that would work for that patient because each of those had a lower likelihood of getting rid of overgrowth. Cipro, it turns out, is one of the better ones for getting rid of overgrowth. The problem with Cipro is if it worked once, it almost doesn't work again because resistance occurs. You don't get resistance to rifaximin. The second is Cipro can cause problems with tendons and joints, or mostly tendons, tendon rupture, actually. And so we sort of gravitate away from Cipro these days, but I know part of the reason this question comes up often in my talks is because rifaximin is so darned expensive and Cipro is cheaper. So if Cipro can work, but have a plan after Cipro because you may only get one shot at it and it may not work the second time.
Victoria, you want to unmute?
Yeah, thank you so much, Dr. Pimentel, for coming and answering our questions today and giving such a very informative talk. Um, my question actually relies on the SIBO and the variations in the bacteria that cause the different symptoms of diarrhea versus constipation. Have you found that those bacteria can flip-flop over time and cause some patients to have diarrhea for several weeks and then flip back to a more constipation heavy bacteria? I'm curious because I myself suffer from that, but I've also known of a lot of other gastroparesis patients that talk about this flip flop that tends to happen back and forth.
Yeah. So generally what we see is that if you're methane, you can go from methane to non-methane, but you can't go from non-methane to methane. So we don't see people who've never been a methane producer become a methane producer. It's very rare. But we have seen people where they were methane, we get rid of the methane, and now they have diarrhea because they have some of the other organisms because they have a tendency to overgrowth and they don't overgrow with methane, but one of the other ones that can cause diarrhea. But in general, SIBO oscillates. So we see patients where, depending upon what they've eaten or how they've eaten over the previous 2 weeks, you can increase the bacterial levels. Let's say you ate beans for a week, and I know that's an exaggeration, but if you did, you would have much higher bacterial counts, and next week you'll have more diarrhea. There's by definition, what I'm trying to say is SIBO is oscillating because it depends on what you eat. The bacterial levels go up and down over time. When they're up, you're more sick. When they're down, you're less sick, meaning more diarrhea, less diarrhea. So it's really all over the place is a classic feature of SIBO.
Fantastic. Thanks so much for that answer. I really appreciate it.
Yeah.
If we have time for one last question that just popped in, saying, once you have the pop procedure, can gastroparesis come back? I've had trouble eating again, getting full very fast. Has an ileostomy now, muscles stop working. And let's see, lives in Pennsylvania now, going to Cleveland Clinic, did the surgery. J pouch was fine, just muscles not working.
Um, yeah, so because you have an ileostomy, so ileostomy patients sounds like the ileostomy is now that hasn't been undone. Um, Ileostomy patients have less SIBO because there's less backflow. I know that I said colon bacteria don't come into the small intestine. That is true, but you can have pressure that can be created from a colon. I mean, in general, what I would like to do in somebody who's had multiple surgeries, though, is I always worry about adhesions affecting the small bowel, which can um, make the gut slow, make you feel like you have gastroparesis again, but it's actually adhesions. So it sounds like you've had a long and very complicated technical surgical history. So I'd have to review that in more detail to give you a clearer answer. And I don't want to be vague, but there's a lot there that needs to be unpacked.
One last one just popped in. Do you have time for one more question?
Sure, no problem.
Okay. It says, do you need to go beyond 90 minutes on interpreting the breath test for gastroparesis patients?
So generally speaking, the consortium on breath testing says 90 minutes is the cutoff, but there are patients where suddenly at 105 minutes the breath goes from 10 to 100, and so you have to. If the patient has gastroparesis, you have to put that in context. So, like any test that you do, you don't just stick with the raw test. You have to put it in the context of the patient, and I would probably call that positive for that patient.
Well, thank you so much for all of this. It was super informative for myself, and it sounds like for everybody else too. This is information that we don't tend to get, as you alluded to, for some of our doctors don't have the access to the information. So thank you so much. And thank you to everybody for being here today. Once this is uploaded and edited, we will get this up on the channel and I'll let everybody know when it's available. So thank you, everyone, and have a great rest of your week.
All right, take care. Thank you.